Okay, thank you very much. It's a great pleasure to be here this morning and to have an opportunity to present to you some of the work that I've been involved in over the last few years. I've been involved in devising applications for testing the therapeutic utility of stem cells in the field of orthopedics. The basic work that I've been involved in centered around a number of questions, which were: can you devise methods for delivering stem cells to damaged tissues so that you can effect a therapeutic recovery? So let me tell you a little bit about this. I'm going to talk about the characteristics of stem cells which make them interesting in the field of tissue engineering. I'm also going to talk about some ideas and some data that we have about how stem cells change in disease. And then I'll tell you about some of the clinical applications that I've been involved in involving mesenchymal stem cells. So the essential characteristic of a stem cell is that it has the ability to differentiate into a number of different cell types. And that's clear here. The stem cells that we work with, which we isolate from bone marrow, can differentiate into chondrocytes, into osteocytes, and into adipocytes. And the conditions under which this differentiation occurs have been very well characterized. We know exactly what signals are required to induce the cells along each of these pathways. We also know a lot about the phenotype of the differentiated cell. We've characterized the differentiated cell to a fairly good extent, and so we know a lot about that. Stem cells can be isolated from an aspirate of bone marrow. A small biopsy of bone marrow can give rise to produce a reasonable number of stem cells, which can then be purified and expanded in culture. The process of culture expansion of stem cells is pretty simple. Basically, a bone marrow aspirate is fractionated on a density gradient system, and then the cells that isolate at this particular density are plated. The adherent cell population then represents the mesenchymal stem cell fraction of bone marrow. The non-adherent hematopoietic stem cells are removed during the culture process. So we end up with a culture-expanded population of cells which are relatively homogeneous and which can then be passaged and expanded through further generations. We can characterize these cells by virtue of their reactivity with a number of surface antigens. These are antibodies which recognize particular molecules on the surface of stem cells, and you can see here in the case of the SH2 antigen, for instance, at day 2 of culture, the cells are negative, but as culture proceeds, we're isolating a population of cells which is positive for the SH2 and SH3 antigens. There are other ways that we can look at the stem cell nature of these cells, for instance, by loading the cells onto a ceramic cube and then implanting that cube subcutaneously in a nude mouse. What we see after a period of about 6 weeks in vivo, we see formation of areas of bone and cartilage on these ceramic cubes. And we've done enough labeling studies today to be clear that the bone and cartilage that we see formed on these cubes arise from the implanted cells, not from the host cells. Let me focus for a minute on chondrogenesis, because that's been of particular interest in the area of cartilage repair. We've been very interested in the pathway whereby a stem cell from bone marrow can become a mature chondrocyte. And we've looked a lot at the growth factor signals and cytokines that induce the cells along this pathway. We've also looked at the cartilage-specific matrix molecules that are expressed by these cells as they differentiate along the chondrogenic pathway. This shows RT-PCR analysis of a number of cartilage-specific molecules expressed by stem cells during chondrogenic differentiation. So aggrecan, this shows the undifferentiated cell on the left going through each day of differentiation up to day 14. We see that aggrecan expression is detected fairly early in this process, aggrecan being a major proteoglycan of articular cartilage. Type 2 collagen is expressed rather late in the process, after about 7 or 8 days. This protein, 36K protein or chondroadherin, also expressed rather late in the process. In fact, the 36K protein is involved in collagen fibrogenesis, so their expression seems to be parallel. COMP is expressed after about 3 days in chondrogenesis, and this molecule, FIBROMODULIN, turns up within 24 hours. All of these molecules are abundant in normal articular cartilage, and so their expression by these cells indicates that the phenotype of these differentiated cells at least resembles that of articular cartilage. Versican is a proteoglycan more commonly associated with fibroblasts than with chondrocytes, but this also is expressed throughout this differentiation process. And this illustrates the histological appearance of these cells as they're induced along the chondrogenic pathway. This is in an alginate layer system, basically cultured in the presence of TGF-beta3 for 14 days in an alginate layer system, or in a pellet culture system, which is simply a micromass format. The alginate layer provides a more optimized formulation for chondrogenic differentiation of stem cells. You can see that you get a more uniform staining for type 2 collagen. You get less heterogeneity than you see in the pellet culture on the right. And when we screen for growth factors which can induce these cells to differentiate into chondrocytes, and some of this slide is cut off on the left-hand side, basically we looked at a large panel of growth factors to try and determine which ones would induce chondrogenesis in these cells, and only one group, those are the members of the TGF-beta superfamily, have this effect on human stem cells. All these other factors, FGF2, IGF2, PDGF, PDH, LIF, and so on, fail to induce chondrogenesis in this culture system. Only the members of the TGF-beta family up here on the top left actually succeed. And you can see the chondrogenic activity because of the abundant saffron and O staining in these cultures here. So not many growth factors have the chondrogenesis-inducing effect. And this is somewhat surprising because of the well-characterized effect of FGF2 and IGF2 on chondrocytes, for instance. Okay, so this slide kind of summarizes the tools that we have available to us to characterize these cells and their differentiation potential. This happens to relate to stem cells isolated from goat bone marrow, but the principles are exactly the same. This shows the monolayer appearance of these cells, the undifferentiated cells in monolayer culture. This shows the reactivity with specific antigens or specific antibodies that we can use, in this case SH4. This shows osteogenesis with induction of a calcium-rich matrix. And these two pictures down here show chondrogenic activity of stem cells. This shows saffron and O staining for proteoglycan, and this one shows type 2 collagen staining. So these are the sort of tests that we can use to characterize these cells in terms of their culture and differentiation. We can also, as I mentioned previously, use the ceramic cube assay, which is the in vivo differentiation assay, to look for areas of bone and areas of cartilage when these cubes are implanted subcutaneously in newt mice. So the tools we have available are somewhat useful, but still somewhat limited in terms of characterizing these cells. And I think we have a lot of work to do still in terms of identifying the undifferentiated cell and also defining the differentiation pathways. This is a slide that I like to include because I think it illustrates a couple of important points. This is the glenohumeral joint in a fetal mouse, about 13.5 days DPC. This is the scapula. This is the humerus. This is prior to joint cavitation, prior to formation of a joint space. And all of the cells that you can see here are chondrocytes at this point. But those cells which are destined to become articular chondrocytes are already distinguished from those cells which are destined to undergo endochondral ossification. So the chondrocytes which represent the future bone cells are already distinct from the chondrocytes which represent the future articular layer, even prior to the point of joint cavitation. This shows staining for FIBROMODULIN, which I mentioned a few minutes ago, clearly distinguishing those cells at the articular layer from those cells in the bone compartment. If we look at another molecule in developing cartilage, this time it's CMP, or cartilage matrix protein, now we can see in the same developing limb exactly the converse. Those cells which will undergo endochondral ossification now express this protein CMP. Those cells which will become articular chondrocytes and form the future joint do not express CMP. So already at this point of limb development, these cells are programmed to become articular chondrocytes or not. And it's interesting that these two molecules which I'm illustrating here, FIBROMODULIN and CMP, FIBROMODULIN is expressed by stem cells within 24 hours of induction of chondrogenesis, and CMP is not expressed by stem cells upon induction of chondrogenesis. That suggests, it does no more than suggest, that the phenotype of the differentiated cell that I've been referring to in vitro is the phenotype of an articular chondrocyte. Okay, so let me present a hypothesis surrounding stem cells and their biological role. And this is divided into three statements. The first says that stem cells, because of their ability to self-renew, they form the natural units of regeneration of a variety of adult tissues. I'm talking now about adult stem cells, which can be isolated from bone marrow and also from a lot of other tissues, including adipose tissue, skin, peripheral blood, skeletal muscle, and so on. So the first part of this hypothesis says that these stem cells actually represent natural units of regeneration of tissues damaged as a result of trauma or disease. The second part of the hypothesis says that in certain degenerative diseases, stem cell populations are depleted or altered. And the example that I'm going to talk about is osteoarthritis. And thirdly then, as a result of 1 and 2, the third part says that if you deliver stem cell preparations to the OA joint, you could devise a potentially effective therapy. So let me address each of these points in terms of some experiments. And the first one of these concerns the characterization of stem cells in a patient population with advanced osteoarthritis. The reason this work came about was I was very interested in looking at the possibility of using a stem cell therapy approach to treat osteoarthritis. Osteoarthritis is a basically irreversible degenerative disease where there's a great deal of damage to the joints. It's essentially a disease for which there is no effective therapy today except for joint replacement. So I wondered if we could use a cellular approach for treating these diseases. But the first question was, what kind of stem cell populations are there, what stem cells can be isolated from these patients? So the experiment involved the following. Basically, we took bone marrow aspirates from a number of patients who were undergoing joint replacement surgery for osteoarthritis. The bone marrow samples were taken from either the iliac crest in the pelvis or from the site of surgery, either the hip or the knee. And we isolated stem cells from each of these aspirates. We then compared these to cells isolated from normal donors in terms of their yield and expansion, and also in terms of their ability to undergo differentiation along these three pathways: chondrogenesis, osteogenesis, and adipogenesis. The hypothesis was that these stem cells would be either depleted in number or functionally depleted in these patients that had this advanced disease. And these individuals were undergoing joint replacement surgery, therefore they had basically end-stage osteoarthritis. And the results of this small experiment were very interesting. First of all, looking at the proliferative capacity of cells isolated from patients with osteoarthritis versus normal controls, clearly there's a significant loss of proliferation in these cells. And that's the same whether you isolate the cells from the iliac crest or from the tibia or femur, the site of surgery. So this is a systemic observation. The stem cell population in the bone marrow of individuals with osteoarthritis is depleted in terms of their ability to proliferate compared to normal controls. This is a small experiment. I have to emphasize that at the start. It's with a relatively small number of patients, about 30 patient donors. And the patients, the patient and control group are not exactly age matched. because of the difficulty in getting bone marrow samples from normal aged donors. So this is a preliminary study, and I think it needs to be expanded on with much bigger numbers before we can be fully confident. However, it does show this difference in the ability to grow. When we look at the differentiation capacity of these cells, we look first of all at chondrogenesis. What we see is a significant loss of chondrogenic activity in those cells taken from OA patients versus controls. This on the basis of, again, of a relatively limited sample size is not an age-dependent phenomenon, but it's a disease-related phenomenon. Whether the sample is taken from the iliac crest or from the site of surgery, we see the same thing. We see a loss of chondrogenic activity. Osteogenic activity we find is increased in the patient population compared to controls, although this result is not significant in this experiment. This shows some of the histological staining of these osteogenic cultures under control conditions and under conditions where osteogenic supplements are added to the culture. And you can see the calcium deposition in the culture. And when we look at adipogenic activity, we find again a significant loss of adipogenic activity in cells taken from OA donors compared to normal. This is by measuring the amount of lipid formation using a Nile red stain. And again, this result is significant. This shows the appearance of some of these cultures. This is the Nile red staining or oil red staining of lipid-filled vacuoles in these cultures. So the conclusion from this experiment, and again, let me stress that it was a fairly small and preliminary experiment, but the results were interesting, that in osteoarthritis, individuals with advanced osteoarthritis, their stem cell population has reduced proliferative capacity, reduced chondrogenic activity, and reduced adipogenic activity. And these results were very interesting in the context of an autologous cell therapy, because that was the thinking at the time, that you would prepare cells from the patient's own bone marrow, culture those cells in the laboratory, and then deliver those cells back to the patient. And it seemed, on the basis of what I just showed you, that that was not a viable approach because the cells were already compromised in these individuals. So we'd have to move to an allogeneic therapy, that is, taking cells from a donor and delivering them to a recipient. And that's the pathway that we took, and I'll tell you a little bit more about that in a moment. However, if these stem cells are altered in this disease, we have to separate we have to determine whether this is a secondary effect caused by the disease environment or whether it's a primary effect, a primary component of the disease itself. And one strong possibility is that the cells are actually altered by the inflammatory environment of osteoarthritis. That turns out to be the case, and that's what we see here. Because when we culture these cells in the presence of two inflammatory cytokines which are upregulated in osteoarthritis, TNF-alpha and IL-1 we find that both of these, when they're added to these cultures, cause the complete loss of chondrogenic activity. So this shows the control culture where the cells are grown in the absence or presence of TGF-beta3. TGF-beta3 induces a rapid chondrogenic phenotype. However, if these same cultures are maintained in the presence of either of these cytokines, TNF-alpha or IL-1 now we completely lose chondrogenic activity. So it may be that the effect that I've been talking about is a secondary effect because of the inflammatory environment of the disease. You can see that here again looking at the histological stains. This shows cells cultured control cultures with TGF-beta3. This shows the same cultures but in the presence of TNF-alpha or IL-1 You see a loss of chondrogenic activity. Interferon gamma doesn't have any effect on the chondrogenic activity of these cells. So we're beginning to see a sort of a theme building up here where the capacity of these cells to differentiate is clearly altered by the environment in which the cells find themselves. Specifically in this disease environment, whether it's a primary effect or whether it's a secondary effect because of the elevated levels of cytokines, nonetheless, we're seeing changes in the behavior of the cells in osteoarthritis, which will have significant consequences in terms of the therapeutic approaches that we can develop. This shows just another small experiment. In this case, we're taking synovial fluid from the joint of patients with osteoarthritis. So this is synovial fluid from the inflammatory disease condition. And we're culturing cells in the presence of medium conditioned with this synovial fluid. This again shows a normal controlled culture here at 7 days and 14 days. It's just typically normal chondrogenic activity. But when we maintain these cultures with TGF-beta 3, but in medium also conditioned with synovial fluid taken from the OA patients, the synovial fluid is diluted 1:20. In this case, we see really no difference between this culture and this culture. However, if the cells are pre-treated with synovial fluid for 2 days prior to the addition of TGF-beta, now we see a very significant loss of chondrogenic activity. At 7 days, there's no differentiation, and at 14 days, there is some, but it's not as abundant as we see in the others. So clearly, there are factors in this synovial fluid which are having a dramatic effect on the cells in terms of their ability to differentiate into chondrocytes. Because one of the major symptoms of osteoarthritis is the loss of articular cartilage, then that there's an attractive idea building here, I think, that the inability of the stem cell populations in these individuals to regenerate articular cartilage may be at least a contributing component in the disease. Okay, so the next part of the hypothesis that I mentioned a few minutes ago concerned the use of stem cells therapeutically. If we can demonstrate that stem cells are involved in tissue regeneration, that they're altered in disease, then maybe we can devise applications for taking advantage of delivered stem cells. Again, in the context of osteoarthritis, we developed a number of surgical models which would lead to a condition which would basically simulate osteoarthritis. All of these experiments were carried out in the goat. The goat turns out to be a very useful model for this kind of study. The goat knee joint is, in terms of anatomy, very similar to the human knee joint. The goat is obviously a large animal. It's an active animal, so the kind of forces which are imposed on the knee joint are realistic. And we found that when we carried out a surgical procedure which involved complete removal of the medial meniscus plus resection of the anterior cruciate ligament, that after a period of several weeks, we began to see lesions in that knee joint which were very similar to osteoarthritis. And after a period of 12 weeks, we found that the changes in the knee joint were essentially analogous to those we see in osteoarthritis in humans. So this was obviously following on the work which had been done in many other species, most notably the dog and the sheep. And then variations of this type. This is looking down on the tibial surface. So this is the medial meniscus here, which we remove, and this is the anterior cruciate ligament, which we can resect. Variations of this include just removing the meniscus, the medial meniscus, but leaving the ligament intact, or thirdly, removing a portion of the meniscus, of the medial meniscus, and leaving the ligament intact. This is more typical of human injury, of human meniscal injury. So let me tell you about a study that we carried out, which we refer to as Baltimore 1, because it was the first animal study that we did, large animal study that we did to evaluate the therapeutic potential of stem cells in this kind of model. Again, it's some of the detail is lost on the left-hand side. So we take a group of animals, we isolate, we harvest bone marrow aspirates from each of these animals. This is an autologous study, so it involved the use of cells taken from the animals themselves. We take a sample of bone marrow, we isolate stem cells from this sample, we transduce the cells to express green fluorescent proteins so that we can track the cells later on. Then at time 0, we carry out this surgical procedure involving ACL resection plus meniscectomy. The animals are given a 2-week period to recover from the surgical procedure, and then they're put on an exercise regime which involves a daily exercise schedule which is imposed and which basically goes on right through the end of the study. 6 weeks after the surgical procedure was carried out, the GFP transduced cells were delivered back into the knee joint. We were particularly interested in using a very simple approach for getting the cells into the knee joint. So it wasn't an open surgical procedure, it wasn't an arthrotomy. The cells were not loaded onto a 3-dimensional scaffold or by a matrix. The cells were delivered by a simple intra-articular injection into the closed joint. So it was a simple injection of cells into the joint space directly into the synovial fluid environment. And a dose of cells consisted of 10 million cells suspended in a volume of 5 mils, and the vehicle was dilute hyaluronic acid. So it's a very simple method for delivery of the cells that does not involve a scaffold of any kind. And in this particular experiment, the cells were delivered in a single injection. And then 6 months later, or 20 weeks later, 3 months from the start of the study, or 6 months from the start of the study, the animals were sacrificed, the joint tissue was harvested. The observation that we made, which was most dramatic and I think unexpected to us, was that in those knee joints which had received cells, which had been treated with cells, the primary observation that we made was an accelerated repair of the meniscal tissue which had been removed previously. So at the beginning of this study, again now we're looking down on the tibial plateau, this medial meniscus had been completely removed. What we're seeing in these joints is an attempt at repair of the medial meniscus. And that's illustrated in these diagrams here, showing where we see this new meniscal tissue formed. You can see it here, here, and here. This is an example of the tissue excised from the joint. And over here, you can see this is the medial tibial plateau, and this is the tissue still in situ. So what we're seeing is an effort to repair the meniscus, which extends from incomplete to almost complete in these knee joints. And this was a phenomenon associated with the cell treatment, and much less evidence of repair of the meniscus in the control joints, which were treated with the vehicle only. Histologically, this newly formed tissue looked essentially like a normal meniscus, and this shows the histological appearance here. It's basically a fibrocartilage. It's got regions of cartilaginous proteoglycan-rich zones, and it's got zones rich in type 1 collagen. It's a mixture of type 1 collagen producing and type 2 collagen producing cells. So it's a fibrocartilage, exactly what we would expect for a meniscus. But the question now is, does this have any benefit on the knee joint? So we made this observation that there was apparently an accelerated repair of meniscus in these previously meniscectomized joints. But the question was, what did that do in terms of protecting the joint from the degenerative changes that we see in this model and that we normally associate with osteoarthritis? So there's a few things that we look at. This is the medial femoral condyle, and there's basically 3 properties that we're looking at here. Number 1 is the articular cartilage. To what extent is it damaged? So you can see in this section here, it's obviously very severely damaged. A lot of the tissue has been lost. You see this fibrillation, loss of staining, and so on. Number 2 is the formation of periarticular osteophytes, or bony remodeling, in an attempt to redistribute the abnormal loads imposed on the joint. You can see that's very dramatic here. And number 3 is an increase in the density of the trabecular bone that you can see here, again as a result of the abnormal mechanical forces. And when you compare this one with this one, this treated with the vehicle, this treated with cells, you can see that there are clearly differences in terms of those 3 parameters that I just mentioned. But when we look at all of the condyles from the control group versus the treated group in this first experiment, you can see that there's clearly a trend here in terms of protection of the condyle from the changes associated with loss of the meniscus. So here you see loss of articular cartilage here and here. Here also formation of really dramatic osteophytes. There's one over here, except it's off the screen. Also here. Whereas these ones in the cell-treated joints appear to be, they're certainly not perfect. There's damage to the articular cartilage here, no doubt about that. But the extent of damage seems to be significantly less in these ones than it is in these. These are the two worst of the cell-treated knee joints. Here, for instance, you can see this really dramatic subcondylar sclerosis, presumably resulting from the loss of cartilage on the surface here. These two joints in this experiment were where we saw the least evidence of new meniscal tissue formation, which leads to the conclusion that the formation of this new, what we refer to as neomeniscus, contributes to the protection of the joint in these animals. Then the next question was, how much of the implanted cells are associated with this newly formed tissue? And remember, the cells were GFP transduced, so we could track them subsequently. And this shows just a panel of fluorescent sections of the neomeniscal tissue. Clearly, the cells are associated with this tissue. You can see that's very obvious here and here, but mostly on the surface. The cells are mostly associated with the surface of the newly formed tissue. When you look in the deeper regions of this tissue, you find smaller numbers of cells. So it's a surface phenomenon. And what's going on here is tissue formation that consists of cells both derived from the host and implanted cells. So it's a mixture of host cells and delivered cells. So in that sense, it's not tissue engineering per se where the delivered cells form a new tissue. It's an interaction between the delivered cells and the host cells that leads to this more optimized repair. Now, since that first study, we've done several other studies, larger and larger studies, to try and make sure that they sort of prove the concept. And in all of these studies, we get this consistent observation that there's a accelerated repair of the meniscus in these joints as a result of the cell therapy, and that this newly formed tissue contributes to the protection of the joint from the changes that we would otherwise see in this model. This is another example here. In this particular study, this was taking allogeneic cells, cells from unmatched donor goats delivered into these recipient animals. You can see the unoperated you can see the contralateral control here. So this is the normal meniscus. You can see the operated joint here, and this shows the newly formed meniscus. So this is really dramatic. This is the unprotected surface of the medial tibial plateau, which you see here. But all this area of tissue here is newly formed, newly repaired meniscus. And when we measure the AP distance, the anterior-posterior distance of a length of unprotected tibial plateau, we find a significant difference in this group here, for instance, versus this group. This is interesting because in this experiment, unlike the previous one, the cells were delivered 1 week after surgery. And here we get actually a better result than when the cells are delivered 6 weeks after surgery, as you can see here, suggesting that the earlier the delivery of cells following injury, the more effective the outcome is. And I think this gives rise to some new interesting questions that relate to the role of these cells in modulating the wound repair response. So again, we're thinking less and less of tissue engineering and more about wound repair and modulating the wound repair response in these animals.
Right, that's a question.
Sure.
Just 3 to 4. 3 is HA and MSCs. 4 is just MSCs, not delivered from HA.
No, 3 is HA only. 4 is HA plus MSCs. Not clear in that.
Okay.
So 1 and 2, the animals were treated 6 weeks after surgery with either hyaluronic acid or with hyaluronic acid plus cells.
This is showing exposed areas of higher
Yeah,
force.
right. So the higher is worse, exactly. The closer to zero, the better the result. And this shows again another example of the macroscopic appearance. This is a treated joint. Again, this is the medial tibial plateau here, and you can see the repair tissue formed here, really offering some degree of protection compared to a control where there's some tissue formation clearly, but it's less than we see here. And this is a consistent observation that you get a response in both control and treated knee joints, but the response is better in the cell-treated joint by mechanisms which we still don't understand, but on the basis of a very large number of studies now, it's the consistent observation that we get a better cartilage repair response in these treated joints. And when we're now starting to use microcomputed tomography, and I'm clearly in a place where there's a great deal of expertise in the use of micro-CT for measuring bone changes. We're looking for more quantitative methods to measure the differences between the cell-treated and the control joints. One of these is micro-CT. We're seeing, again, differences in terms of trabecular bone spacing between the control and cell-treated joints, and also in trabecular bone number. We're sort of just getting into this work where we're developing the methods right now. And again, the preliminary data are showing that there are substantial differences between cell-treated and control joints in terms of bone structure. This gives an example of the articular cartilage taken from a condyle treated with cells versus treated with vehicle only. And this is obviously the best versus the worst, but the consistent observation that we make again is some element of protection of the cartilage. Maybe it's a secondary effect associated with this, the cushioning effect of the new meniscus, or maybe there's a primary effect involving the cells that we don't yet understand, but we do see this observation. When we look at this in a sort of using a multi-parametric histological scoring system, we see again significant differences in terms of histological appearance. And just finally, just to mention very briefly, the next question that we were interested in was, if we see this effect when we deliver cells in a single dose to these knee joints, what if we do multiple doses? So it was sort of a dose range finding thing. This study was done in Cleveland, so that's why we refer to it as a Cleveland study. Basically, what we're doing is we're delivering cells in 1 or 3 injections. So it'll be a dose of 10 million cells versus 3 doses of 10 million cells each into the knee joint, this time in a partial rather than a full medial meniscectomy. And let me just draw your attention to the bottom 2 panels down here. What we found in this study was that 3 injections represents a significantly better response than a single injection. You can see that here, where cells delivered in a series of 3 injections at 1, 2, and 3 weeks following partial meniscectomy versus cells delivered in a single injection, you're getting a substantially greater amount of neomeniscal tissue formation in the 3 injection series than you are in the 1 injection series. This experiment again illustrates to us how hyaluronic acid is useful, because in this group where the animals were treated with cells in PBS rather than hyaluronic acid, we do see a difference between the cell-treated versus control, but the scale is much different between these two. So hyaluronic acid is clearly the optimal vehicle for delivering these cells. And the most useful therapeutic approach involves a combination of cells plus hyaluronic acid. If you leave out the cells, nothing happens. If you leave out the hyaluronic acid, you get a lesser response than when you have hyaluronic acid plus cells. So it's a sort of a magic combination of the two of these. And finally, this illustrates just 1 or 2 of the, so this shows the neomeniscal tissue formed following a single injection. This shows what happens when you get 3 injections. Again, it's lost over there on the left, but this is 3 injections versus a single injection. We're also using MRI to try and evaluate meniscal tissue formation in these joints, because this is an important surrogate endpoint that's used in patients, and so we're also applying this to our animal studies. So this shows a meniscectomized knee joint that's untreated. This is where the medial meniscus should be. There's essentially no effort at repair in this, evident by MRI, but you do see this subchondral cyst here. This shows a normal medial meniscus right here, and this shows a repair meniscus here in a cell-treated knee joint, with evidence by MRI of an attempt at repair of the meniscal tissue. This was these images were taken on live animals, so now we can we can carry out a linear study using MRI to follow the repair or the formation of new meniscus in these animals. So where does all that get us to? Well, this is the sort of idea that we end up with at this point. Our therapeutic approach now consists of a preparation of mesenchymal stem cells isolated from bone marrow, mixed with hyaluronic acid, delivered by intra-articular injection to the knee joint, where the meniscus has been damaged, and the intention is that those cells will accelerate the repair of the meniscus. So the product concept that we have consists of the following. We have a preparation of cells, a vial of hyaluronic acid. They do need to be mixed shortly before delivery, so the mixing takes place basically at the clinical site, and the idea we have is a sort of a syringe arrangement where the cell suspension is in a single syringe, the vehicle is in a second syringe, and by back and forth mixing. Remember, the hyaluronic acid is very viscous, so the mixing has to be done very gently to avoid damage to the cells by the shear forces. So the back and forth mixing of the cells plus hyaluronic acid, we end up with a uniform suspension of cells in the hyaluronic acid. That suspension is taken up into one syringe, which is then used for delivery of the cells to the knee joint. And the dose consists of approximately 10 million cells. It'll probably increase somewhat in the human knee joint, and we're planning to start clinical trials in this area, hopefully in 2003. So I think that's the end of the story, except to acknowledge all of the participants, all of my colleagues at Osiris who have participated in this work. There are many, many others, and also some of our external collaborators who have helped us along the way. So that's it, and thank you very much.
Question back there.
You talked about how the stem cells from patients with advanced osteoarthritis have reduced ability for proliferation, maybe, and chondrogenesis. Do you think that maybe the success of the cell suspension injected in goats had something to do with the fact that they were healthy and the injury was induced?
I think so. The cells were either isolated from bone marrow aspirates taken from these animals prior to injury, so they represented healthy populations, or they were taken from different uninjured animals. In either case, I think these represented a healthy population of stem cells which could at least contribute to the formation of the new tissue. The animal experiments that I described don't really address the question about how these cells are involved in the development of osteoarthritis. I think we'd have to use a different surgical model that didn't involve so much instability in the knee joint. And in fact, that's something that we're doing right now. But I think the hypothesis is that in these injured knee joints, there is a depleted stem cell population, so the contribution of those cells to repair is less. So if you can enhance that population by adding exogenous cells, then you can accelerate repair or improve the outcome. That's the idea. I think that's what the animal studies show. But there's so much in between that we don't understand.
Right, I'm just wondering, since the synovial fluid in patients, human patients, will not be the same as in healthy
So, yeah, that's a very good point, and the protocol requires removal of the synovial fluid before delivery of the cells. So the joint is aspirated completely, so all of the synovial fluid is removed. But yeah, that's a good point.
You looked at GFP cells in the neomeniscus, and you saw in some of those joints that there was articular cartilage damage. Did you look for the GFP cells on the surface of the articular cartilage?
Yes, we did. That was something we were very interested in doing. We could not see GFP-labeled cells on the surface of the articular cartilage, even though we saw healthier cartilage in these groups. And on the basis of in vitro explant cultures that we'd done, clearly the GFP-labeled cells do adhere to fibrillated articular cartilage. We did not see it in these animal studies, and I don't know the reason for that. It may be the shear forces on the joint because these are exercised animals, or it may be other factors.
Did you look at the one, the second study that you showed, the Cleveland study, because it was multiple injections over time?
Yes, we looked, and again, we didn't see the GFP-labeled cells on the cartilage.
How did you land on a number of 10 million cells? I mean, do you know how many you're losing in the injection process? How many are
That's a very good question, and there's no very good answer. It was based entirely on logistics of how many cells you could prepare in this volume and mix with this amount of hyaluronic acid. There was no good reason for selecting 10 million cells, and it's a question that we now have to address actually as we prepare for clinical trials. We have to do a sort of a dose optimization study to demonstrate that 10 million cells is actually the best dose. But there was no good reason. We sort of just selected it out of the blue.
So you don't find that they migrate out of the joint, or do you lose any in the injection process?
We have no way of knowing that, and that's again a very good question. And some people express concern about the possibility that these cells would actually leave the joint space, go to another site, and then form bone or cartilage, so you get this ectopic tissue formation. We've done some whole body pathology in these animals, and there's no evidence at all of any ectopic tissue formation. We're continuing to do, because we need to for regulatory submissions, we're doing much larger safety studies at this point. I don't think we'll see any adverse ectopic tissue formation like that, but it is a question that does come up.
I noticed that your data show that hyaluronic acid is a better vehicle than PDS for your cells. However, do you have any concern from the timing study where you show injections at 1 week versus 6 weeks, and you saw the greater difference between your treated and untreated controls at 6 weeks? But could it not have simply been that your untreated, the HA label, had a higher value indicating less repair, that you had a larger exposed surface that you were measuring, but you weren't getting as much meniscus? Because it seemed as if your vehicle group increased, but your treated groups really didn't change from 1 week versus 6 weeks.
Yeah, I think that's where we do need to rely on better methods of measurement, and there's clearly a difference between the HA-treated versus cell-treated group at 1 week. That difference is less clear at 6 weeks. But I think when we go on then to do the series of 3 injections versus 1 injection, these differences become much more substantial. And this is where we do need to rely on more quantitative techniques. But it is a good point, and it is something that we've sort of taken into account.
Just to kind of follow up on that first question, you mentioned how you believe there's an interaction between the cells of the animal and the MSCs that you're providing. So is the clinical indication for a repair type approach, for an injury repair model, or an associated with like a degenerative disease like osteoarthritis, where you may not have the suitable interaction?
Yeah, so right now the clinical indication is meniscal repair, or meniscal injury. So the idea is that the cells will be delivered to individuals following a meniscectomy to repair meniscal injury. So these are not osteoarthritis patients, clearly. These are much younger individuals who have a traumatic or a sports-related injury. I think we still have some ways to go before we can start using these cells to treat osteoarthritis, although that's where I started out, trying to devise an approach that would work in OA. So I think what we're going to do initially is use this approach for treating meniscus. We need to go back and refine this model, this goat model, to do more studies that make it more representative of osteoarthritis than the instability-induced model. So we have a lot more work to do, I think.
Have you used some specific molecular weight for the hyaluronic acid?
Yeah, it's 600,000 to 1 million molecular weight range.
And have you noticed any difference in the behavior with lower molecular?
Oh, well, no, the material we use has a molecular weight range of 600,000 to 1 million. So it's not very high molecular weight, but that's the spectrum of weights. But we haven't looked at the effect of molecular weight at all. It's too much to do.
Frank, one of the arguments for using a scaffold tissue engineering is to provide a repair template, find the boundaries of repair.
Sure.
Do you guys worry at all about the amount or distribution of repair relative to the native tissue in terms of this? So in other words, is making too much fibrocartilage perhaps a problem for some companies?
It's definitely an issue of concern, but I think that we've never seen in any of these joints that you get like uncontrolled tissue formation or that you get excessive proliferation of cells. It seems that the mechanical environment does help to constrain the tissue repair. And another approach, of course, would be to load the cells onto a scaffold and then attach that scaffold to the damaged meniscus. It seems, however, that the delivery of a suspension of cells does work well enough, and the fact that it's a closed procedure doesn't involve any surgical opening of the knee joint, I think, is an important point.
When you do your series of injections, have you looked at, when you do 3 injections of 10 million cells, have you looked at doing like 3 injections of 3 1/3 million cells to negate getting more cells and
Yeah.
delivering it over time?
That was the other way of doing it, and we chose to do it where we were actually increasing the total dose. But that's certainly another way that it could be done.
You think you'd see differences if you applied the stem cells over time?
I don't know. We've never treated an animal with other than 10 million cells per injection, so I just don't know. We're obviously going to do those studies now because we have to look at sort of dose optimization, but at this point I don't know.
But your data is showing it better to deliver early versus later.
Yeah.
That suggests that there's some benefit to providing a large early bolus of cells.
I think so. And there's also data from other studies involving repair of cardiac tissue following myocardial infarction, which also show a better response when the cells are delivered earlier rather than later. So it's the interaction of the cells with the early wound environment, I think, involving factors that we don't know anything about at this point. It seems to be important.
Do you have any plans to combine your cell treatment with an anti-inflammatory treatment that might extend indication for osteoarthritis?
Sure. I mean, so one of the obvious approaches would be to transduce these cells so that they're expressing a gene which has some therapeutic benefit. So, for instance, soluble TNF receptor or IL-1 receptor antagonist. We've done some of these studies and we've seen very good results in terms of inflammation, and we haven't done them in the goat model where we would look for both anti-inflammatory effect and protection of the tissue, but I think that's something that we would. So the approach would almost certainly be a gene therapy approach where we would use the cells to deliver the appropriate gene, and then the combination of that gene plus the cells would have the kind of benefit that you're referring to. Also, mixing the cells with some kind of pharmaceutical or pharmacological agent is another option. We've not really done any studies in that direction, and it's just like again, a question of time and what resources are available to us.